I'm sure that many of you are aware that we participate in the Cardiac Arrest Registry to enhance survival. That means we look at every cardiac arrest that we respond to, and we report this data into a database which CARES Registry can then compare to everyone else in Wisconsin and to the whole country. And then it provides us with that data, and we can make decisions about where we want to focus our training or what kinds of things we want to try to change in order to improve our outcomes. I recognize that you are able to press the pause button, so I'm going to go through these slides rather quickly and allow you to read them for yourself and draw your own conclusions. The first set compares Wisconsin to the rest of the country, and you're going to see that we're basically the same. There's no big differences between Wisconsin and everyone else. So when I go through these slides, I'm going to let you read them for yourself for the most part, and in a few of them, there are things that require a definition, so I will explain what those measures are. First, when it comes to where cardiac arrests occur, it's no big surprise that most of them happen at home, and then in public, roughly 16% in Wisconsin, and then nursing homes about 7.5%. Whether or not these cardiac arrests are witnessed, about half of them are not witnessed, bystanders about 35%, and then 911 witnesses about 11% of them. The question about who initiated CPR, if it was done, is pretty much the same in Wisconsin as it is nationally. Same thing for AED. If an AED was applied before we got there, Wisconsin and national numbers are basically the same. Did a bystander perform CPR is also the same Wisconsin and nationally. About 35% of the time there is bystander CPR, and then AEDs are used about 9.5% of the time. The first arrest rhythm is either VTAC, VFib, or an AED was applied and it shocked, but we don't know what that rhythm is. So that first category is there about 16 to 18%, and then the other three categories are all non-shockable rhythms. ROSC stands for Return of Spontaneous Circulation, and this is measured by either 20 minutes of sustained ROSC, or they still had a pulse at the time in which you got to the hospital. The first category, survival to hospital admission, means the patient survived EMS and they survived the emergency department, and then they were admitted either to the ICU or med-surg or another part of the hospital. Survival to hospital discharge is roughly a little under 10%, both nationally and for Lifestar, and slightly less than that, they're discharged from the hospital and they have decent neurological function. The Utstein measures are a way that they are trying to focus on what they believe are the most salvageable patients that go into cardiac arrest. So Utstein survival is for when the first observed rhythm on the cardiac monitor by EMS was a shockable rhythm, or the AED shocked the patient, so it was a shockable rhythm. In that case, about 29% of people fit into that category. The Utstein bystander survival rate means that not only did they have a shockable rhythm when first observed, but bystanders also provided CPR to that patient. And that's right around 32% of people wind up surviving when they fit that category. Now let's take a look at the Lifestar numbers and compare them to the whole state of Wisconsin and then to the whole country. Here's the individual report that we get. I have it blown up to make it easier to read. And you'll see that it compares Lifestar to the state of Wisconsin and then to national numbers. At Lifestar, we have 51 cardiac arrests in this category, 3,429 in the state of Wisconsin, and 146,924 nationally. There aren't a lot of differences between Lifestar and everyone else in these categories. There are a few differences, and I'm going to point them out. And again, I know that you can press pause so you can look at these numbers much more carefully if you want to. The numbers that are in parentheses like this, those are the percentages, and these numbers are the raw numbers So the first major difference is right here, this number. 47% of the time we do not record a race on the patient, as opposed to in Wisconsin 9.2 and nationally 16% of the time. Why is this? Well, the easiest explanation I can think of is it's not required in order to validate the report in ESO, and since it's not required, a number of providers are choosing to skip that category. There's nothing wrong with noting a patient's race if it is easy for you to tell, and it's data that might be useful in analyzing healthcare trends nationally and statewide. So I encourage you to put that category in if you can. In this next set of numbers, if you press pause and look carefully, you'll notice that Lifestar versus the state of Wisconsin versus nationally, the numbers are all very, very similar, except whether or not an AED was applied right here. Lifestar numbers are quite a bit higher in terms of whether or not an AED was on the patient prior to our arrival. That's pretty good. It means we have first responders and police officers that are getting out there and putting the AED on the patient. And as we know, that's a critical element to survival. All the rest of these numbers are pretty similar across the board. In this last set of measures, there are some really interesting numbers that are different at Lifestar than everywhere else. And the first one is right here. Did we achieve ROSC in the field? For Lifestar, 9.8% of the time we're getting ROSC, and that is compared to almost 30% in Wisconsin and 27% nationally. That's a big difference. That's something worth trying to figure out why that is. Take a look at these numbers, the Utstein survival and Utstein bystander survival rate. That's looking at the patients that the first rhythm was shockable. And the second group is, not only is it shockable, but somebody agreed to do CPR prior to arrival. And there, when you compare Lifestar to the other categories, you'll see the numbers are almost identical. When there is a shockable rhythm, we are seeing the same successful discharge from the hospital, neurologically intact. 80% of the time, we're calling it in the field, where 47% and 42% Wisconsin and nationally. That's a big difference. Much less ROSC, much more calling it in the field. Why is this happening, and is it a good or bad thing? I can't tell you yet, but it's certainly worth looking at over the course of the next year and figuring out if there's anything we're doing different that is leading to the same success rate in terms of discharge, but we're not transporting the patient to the hospital as often as other services. So that's the 2021 CARES Registry numbers, and we will continue to enter data in the registry, and hopefully next year we'll have some more things to talk about too.